shown the initiative to join or attend a webinar. That itself shows that you have intent to pursue your dream of getting an MDS seat. Now it is up to you to take it forward from here with whatever guidance we have to offer so as to make your dreams come into fruition. My name is Dr. Udhay Bhanu. I have completed my post-graduation in oral pathology and microbiology from Manipal College of Dental Sciences, Mangalore. And I currently have my private practice at a place called Kalpati in Palakkad. And I will be helping you this year in basic physiology, oral histology, and oral pathology. So today, as part of this webinar, we will be having a very, very brief session on one of the more common odontogenic tumors which are seen in the oral cavity, that is the ameloblastoma. Now, before we go into this, there are certain aspects of the subject, especially in our specialty, which is oral histology and oral pathology, that you need to understand so that you can be in a better state of mind while preparing for the examination. Now, the first thing is, when it comes to oral pathology, it's more of a memory game. So you will have to remember how certain disorders look under the microscope, how certain tissues look under the microscope, and what are the variations from normal that you will encounter when you see something under the microscope, which is the histopathological picture. So if you have to appreciate this, the first thing you need to do is to get your basics right. That is where oral histology comes into the picture. So if you are able to identify a normal cell, the aspects, the facets that you would come across in a normal cell, only then will you be able to see through the pathology and detect and make an obvious right diagnosis. So that will form the basis for our preparation for oral histology and oral pathology. The second thing I would like to tell you is oral pathology tends to be more of a memory game. So the person who remembers the most invariably scores the most. There is not much scope to twist things in oral pathology. So you either know it or you don't know it. There are no two ways about it. So there's no way you can work your way around certain things. Okay. So for that, during your preparation, right from day one, you need to familiarize yourself with new terms, at least 4 or 5 new terms every day. How you do this is by going through the glossary of your book. You go to the last page of your book and start from alphabet A and look for all the different syndromes or the different bodies or different aspects of pathology, which will be listed in an alphabetical manner. Go through each of these and at least know what it is. Just know 1 or 2 lines about it. What is it you should know? The idea is not to mug up pages and pages about each and every name. That's not the idea. The idea is to stay familiar with each term. So when it appears as an option, nothing should confuse you. It should be at the back of your mind. It should flash into your memory the moment you see it as an option in an MCQ. So that is the primary aspect. That's number 1. Number 2 is always study around an MCQ. Do not avoid trying to go in pages after pages. Okay. So you should be studying each and every question and each and every option. Okay, and each option should give you an idea of what needs to be studied laterally. So if you see 4 options, each of these options will give you 4 questions. So you have to study at least 1 or 2 lines about each of those options. So that is very important. Okay, so never ignore the options that are being given with each question during your preparatory stage. Of course, in the exam stage, you need to identify each of the options and select the right answer. That's a different matter. But during preparation, please respect all the options, right? And on that note, let's start today's session. So we are going to deal with ameloblastoma. Now, in oral pathology, each and every term is self-explanatory. So if you know the name of a lesion, if you split it, you are going to get an idea of the cell of origin. So if you say ameloblastoma, that means ameloblast. That is the cell of origin. And oma, it's a tumor. So based on the prefix or suffix, you can identify whether it is a malignant or a benign tumor, right? On that note, let us have a brief idea about the different odontogenic tumors which are seen in the maxillofacial region. Now, the odontogenic tumors can be categorized based on their origin. So it can either be from odontogenic epithelium with ectomesenchyme, with or without hard tissue formation, and then the odontogenic ectomesenchyme. So for this, to understand this categorization, you should understand that the odontogenesis, that is how a normal tooth forms, involves three players. One is an epithelial component and one is an ectomesenchyme component, two components, epithelium and ectomesenchyme. So the tumor can arise either from the epithelium or from the ectomesenchyme or from both of them. So that forms the basis for the classification. So odontogenic epithelium, the tumors that arise from it are ameloblastoma, squamous odontogenic tumor, calcifying epithelial odontogenic tumor, and adenomatoid odontogenic tumor. Next, we have the tumors which arise from odontogenic epithelium with ectomesenchyme, with or without hard tissue formation. That means there is an epithelial component and there is a connective tissue component. So the tumors in this are ameloblastic fibroma. Wherever you come across terms which have two distinct components, ameloblastic fibroma, ameloblastic fibroodontoma, ameloblastic fibrodentinoma, calcifying odontogenic cyst or calcifying cystic odontogenic tumor, odontoma, and odontoameloblastoma. Right? So all of these, wherever you come across compound names, that is where you get the clue that the tumor is arising from epithelium and ectomesenchymal component. Now, all of these 6 lesions, all of them will also show the presence of hard tissue formation. Okay, that's also known as dentinoid or enameloid formation. That is something which resembles normal tooth structure but is not normal. It is suboptimal in its composition and structure. Then you have the tumors which arise from odontogenic ectomesenchyme without or with odontogenic epithelium. So this includes the odontogenic fibroma and the odontogenic myxoma. Now let us focus our attention on ameloblastoma. Now ameloblastoma is an odontogenic tumor which arises from odontogenic epithelium only. It has only an epithelial component for its origin. Now, based on its properties and based on its behavioral pattern, it has been categorized by 4 terms. It has been elaborated under 4 terms by a scientist called Robinson. Those 4 terms are very, very important: unicentric, anatomically benign, clinically persistent, and non-functional. Let's go through each of these very briefly. Unicentric. Unicentric means the tumor is starting from a particular point and expands from there. Got the concept? Uni means one. Centric, that is, it has only one center from where it expands. That's called unicentric. Multicentric means there will be multiple points of origin from where the tumor will arise and unite to form a large lesion. Here, the point of origin is only one. Okay. Anatomically benign. Anatomically benign means it is not having the tendency to invade surrounding structures. So it's anatomically benign. Clinically persistent. By the term clinically persistent, we mean that it will not resolve on its own. There are certain lesions that tend to resolve on its own, which may be due to the body's persistent immune system or due to the transient nature of the neoplastic cells. They can resolve on their own. But ameloblastoma is not one of those. It is clinically persistent. It will remain until the lesion is surgically excised. Last and very, very important is non-functional. So an ameloblastoma will resemble, you will see in the histology, you will observe that it will be, the lesion will not have any functional aspect. It will not function. That means the cells will resemble a tooth bud or an enamel organ, but it will not be able to produce any hard tissue component. So these are the terms that describe an ameloblastoma: unicentric, anatomically benign, clinically persistent, and non-functional. Okay, so now we have understood the basic criteria to elaborate on the lesion. Now we have to know which are the cells of origin, the possible cells of origin. The cells of origin can be the remnants of the dental lamina. What are the remnants of the dental lamina called? Yes? What are the remnants of the dental lamina called? The cell rests of Serrae. Yes, the cell rests of Serrae. Okay, so those can be a source for the ameloblastoma. Then also the developing enamel organ and even the basal cell layer of the oral epithelium can act as possible sources for the neoplastic epithelial cells. Now, in order to understand how an ameloblastoma looks and how it starts or originates, you have to understand the structure of an enamel organ. This is how an enamel organ will look towards the bell stage. So you will have a bell-shaped structure like this, partially horseshoe shaped. Okay. And then you have the cells here called the inner enamel epithelial cells and the outer layer, which is called the outer enamel epithelial cells. Okay. You're not able to see the slides? Just a minute, just a minute. How about now? Is it visible? How about now? Okay, just give me a minute. I think there's a technical glitch. Please be online. Sorry about the technical glitch. There was something wrong. It's all right. We'll do it again. Okay. So when you talk about ameloblastoma, the cell of origin is the ameloblast. Okay. And the categorization for odontogenic tumors is based on the cell of origin. That is the odontogenic epithelium. Either it can be from the odontogenic epithelium, or it can be from the epithelium and the ectomesenchyme with or without hard tissue formation. That is when you see these compound names like ameloblastic and fibro. Fibro means connective tissue. So that should give you an idea that there is an epithelial component and a connective tissue component. So ameloblastic fibroma, fibroodontoma, fibrodentinoma, calcifying odontogenic cyst, odontoma, and odontoameloblastoma. Then you have the tumors which arise from odontogenic ectomesenchyme with or without epithelium. So these include the odontogenic fibroma and the myxoma. Now, when we talk about the ameloblastoma, all its clinical features and its pathological behavior has been elaborated under 4 terms by a scientist called Robinson. And those 4 terms are unicentric, anatomically benign, clinically persistent, and non-functional. So all these will describe the pathological life cycle of the ameloblastoma. So unicentric means it starts from a particular point and then expands to spread and reach different parts of the bone and destroy it. Then you have anatomically benign. By anatomically benign, can you see the slide, terms to describe ameloblastoma? Yeah, I think it's fixed now. So the terms to describe ameloblastoma are it's unicentric, that is, it starts from a particular point and then spreads out within the bone. Then it's also anatomically benign, that is, it cannot invade into nearby tissues. It is clinically persistent. Clinically persistent, by the term clinically persistent, we mean that the lesion will not resolve on its own. That is, though it is derived from a synthetically or a secretorily active cell, which is the ameloblast, it does not perform its designated function. That is, the neoplastic cells are non-functional. So they are unicentric, anatomically benign, clinically persistent, and non-functional. Coming to the possible cells of origin. So the cells of origin for an ameloblastoma can either be the remnants of the dental lamina, which are also known as the cell rests of Serre, the developing enamel organ, and the basal cell layer of the oral epithelium. Now, when we talk about the enamel organ, this is how it will look. There will be a cap-shaped structure here, which represents the epithelial component because of its direct continuity with the surface epithelium. And then you have the ectomesenchymal component, which is spread over the space, which has the blood vessels and the supporting stroma or connective tissue. Now here you have the cells which are the inner enamel epithelial cells. These cells. These are the outer enamel epithelial cells, and the cells in the middle are the stellate reticulum-like cells. These pale staining cells are the stellate reticulum cells. Okay, so these are the cells. This is the exact picture that you will also see in an ameloblastoma. So at this point, you will be able to appreciate that ameloblastoma is nothing but odontogenesis which has gone wrong at some point genetically. So it will look like a tooth bud histologically or like an enamel organ histologically, but functionally it is a neoplasm. Radiographic appearance. Radiographically, it will look like a multilocular radiolucency. See this? Multilocular means multiple locules. It will look like a soap bubble. See? You can see one like this, one over here, one over here. All of these are locules. These locules represent the area of massive bony destruction, which is caused by the intraosseous growth pattern of the tumor. That is, the pattern or the nature of the tumor to grow from within the bone outwards, as a result of which the bone tends to be reduced to these empty spaces with thin septae separating each of these spaces. These thin septae give it the typical appearance of a honeycomb or a soap bubble. This is also known as a multilocular radiolucency. So this is how it will appear under on a radiograph. Next, we come to the distinct histological features which you will see in an ameloblastoma. So the basic trio, that is the basic triad of histological pattern which you see in order to make a histological diagnosis of an ameloblastoma, is collectively called the Vickers and Gorlin's criteria. Vickers and Gorlin's criteria. So this will describe the three aspects in a cell which you must see at any cost in order to make a diagnosis of an ameloblastoma. Now, this is very important because you will be seeing subsequently that there are a wide array of histological subtypes in ameloblastoma, which have different behavioral patterns. In each of them, in order to call it an ameloblastoma, at least one particular field in the microscope should show the features pertaining to Vickers and Gorlin's criteria. So the Vicker and Gorlin's criteria are three in number. They are hyperchromatic nuclei, okay, palisading of the basal cells, and polarization of the nuclei away from the basement membrane, and vacuolization, that is subnuclear vacuolization. Subnuclear vacuolization. So these are the features that you have to see in order to make a diagnosis of an ameloblastoma. So you will find that the nuclei will be hyperchromatic. See the color of the nuclei, dark blue in color. They will show a polarization or a reversal of polarity. By reversal of polarity, we mean that the nuclei will move away from the basement membrane. So this is the basal membrane. and the nuclei are directed away from it. See, all of them, you will observe that there is an empty space between the basal membrane and the nucleus. That means the nuclei has moved away. It has undergone a reversal of polarity. After this, you will also find that the cells appear palisaded. By palisaded, you mean that it looks like a fence. If you have observed a picket fence, you'll see that each of the sticks are aligned parallel to one another. So you'll see that the cells are arranged parallel to one another and perpendicular to a basal lamina. This arrangement is called a palisaded arrangement. Then you will also see something called subnuclear vacuolization. That means below the nuclei. That will be seen only in high power. Below the nuclei, you will find empty globular spaces which resemble vacuoles. So these three features, hypochromatism, palisading with reversal of polarity, and subnuclear vacuolization, form the Vickers and Gorlin's criteria for diagnosis of an ameloblastoma. Now, based on the histology, there are 6 distinct histological subtypes for an ameloblastoma. The first one is the histological prototype for an ameloblastoma, which is called the follicular pattern. So in the follicular pattern, you'll see large follicles or globules of neoplastic cells or tumor cells. Then you have the plexiform pattern. Plexiform is where the tumor cells or the neoplastic cells are stretched into thin strands. See this? Thin strands with faint connective tissue in between. That's called plexiform. The third is called the acanthomatous. Acanthomatous is where there is a phenomena of squamous cell metaplasia, which is seen within the ameloblastomatous follicles. The fourth is the basal cell variant. That means within the neoplastic follicle, the cells in the middle will undergo a basal cell change. They will look like basal cells. By basal cells, I mean short cells with a very prominent hyperchromatic nucleus. Then you have the granular pattern. Granular cell ameloblastoma is where the central cells will undergo a floccular appearance with a granular cytoplasm, granular and an eosinophilic cytoplasm. Then last but not the least, you have the desmoplastic ameloblastoma, wherein the connective tissue component is extremely eosinophilic. See, everywhere here, between the neoplastic cells, the connective tissue component is very pale. Have you observed this? See, very pale, fine strands, whereas here, the connective tissue is extremely mature and dense, as a result of which the neoplastic cell follicles get compressed or crushed. See the cells, how they are crushed? They do not have much space to grow. This forms the desmoplastic ameloblastoma. Now, I am going to tell you an easy way to remember the histological subtypes for the ameloblastoma. For that, you should first appreciate this picture. Okay, this picture is how a typical ameloblastoma will look. An ameloblastomatous follicle will look, or a follicular ameloblastoma. So you will have the cells towards the periphery having the Vicker and Gorlin's criteria, and then the central cells will appear like stellate reticulum-like cells. That is, there will be star-like pattern with a peripherally placed flattened nuclei and a clear cytoplasm. This is how a typical ameloblastomatous follicle will appear, or in other words, it will look like an enamel organ. This is how a follicular ameloblastoma looks. Okay. Now, the different histological subtypes are subcategorized based on the changes that you will see in the central population of the cell. In the central population of the cell, and how that change will affect the appearance of the follicle as such. Again, the histological subcategorization occurs based on how the central population of cells, that is the cells which look like stellate reticulum-like cells, these cells, how they appear is what dictates what is the histological subtype. That and also the effect that this change has on the follicle of neoplastic cells. Okay, so now you put this into this picture. So this is the typical follicle. Now, if you take this follicle and stretch it out, you will get plexiform. If the central cells undergo squamous epithelial metaplasia, that means if these central cells which had a clear cytoplasm and a peripherally pushed nuclei undergo squamous epithelial change, they will appear like this: polygonal cells with eosinophilic cytoplasm. Eosinophilia is pink, okay, hematoxophilic is blue, okay. So they'll appear like this with a nucleus, and they will also show keratin pearl formation. See this? Keratin pearl is nothing but areas where squamous epithelial cell apoptosis or cell death has occurred. So it will appear like a keratin pearl. So that's your acanthomatous. Now, if the central cells, if these cells become like basal cells, then you will find that they are short, stout cells with an extremely hyperchromatic nucleus. So you cannot identify distinct cell populations. All of them look very similar here in a basal cell ameloblastoma. Then you have the granular cell ameloblastoma, where the central cells again have a granular cytoplasm. Now these granules are believed to be aggregates of lysosomes. And then finally the desmoplastic, where the stroma or the ectomesenchyme is extremely dense, mature and hyalinized. So these are the 6 histological subtypes of the ameloblastoma. Next you have the unicystic ameloblastoma. Unicystic ameloblastoma is a subtype, a histological subtype of the ameloblastoma itself. It is considered to be less aggressive and less predisposed to recurrence than other aggressive solid tumors. But the catch in unicystic ameloblastoma is that it needs to be excised completely. There is a risk of leaving behind nests of neoplastic cells, which in turn can cause a recurrence and give rise to a new lesion. Now, an unicystic ameloblastoma usually occurs in younger individuals in the posterior aspect of the mandible. The location is the same, but radiographically, it will look like an odontogenic cyst. And on excision, you will find that most of it will very closely resemble a dentigerous cyst. However, on very close examination of multiple sections of the lining, you will find that some areas within the lining will present with the Vicker and Gorlin's criteria. So you can see over here, these cells that are lining the cyst, the so-called cyst, will present with these tall columnar cells presenting with a palisaded appearance, hyperchromatic nuclei, and a polarization of the nucleus away from the basement membrane. So all of these fall into the criteria of Vicker and Gorlin's criteria. And you can also see the stellate reticulum-like cells lining the neoplastic cells. So this is what will give you a clue about the possible diagnosis of a unicystic ameloblastoma. Now there are 2 patterns in which the unicystic ameloblastoma can progress. The first, actually 3 patterns. The first pattern is wherein this neoplastic change is limited only to the lining epithelium. Okay. The second is where these tumor cells can grow into the lumen. It will grow into the lumen. So it will show a luminal pattern of proliferation. Luminal pattern. The third is where these neoplastic cells can bundle out and fall or drop off into the capsule, in which case it is called intramural. That is where it goes into the connective tissue. So these are the 3 patterns that you can see in a unicystic ameloblastoma. Now, when you talk about ameloblastoma, you should also know that there are certain aspects of ameloblastoma which can be considered malignant. So the 2 variants here are the malignant ameloblastoma and the ameloblastic carcinoma. Malignant ameloblastoma is also known as METAM or metastatic ameloblastoma. That is, it is an ameloblastoma which histologically resembles the odontogenic presentation, but it is located at a far site, at a site which is far away from the oral cavity. It has no geographical similarity to its normal location. So the most common site for a malignant ameloblastoma or a metastatic ameloblastoma is the lungs. Very important. The most common site for a malignant ameloblastoma or a metastatic ameloblastoma is the lungs. Now, histologically, they will show no forms of atypia or tendencies of a malignant tumor, but it will not be seen in its original location. But when a malignant ameloblastoma is seen in the lungs, it can cause a high rate of mortality. The next subtype is the ameloblastic carcinoma. Ameloblastic carcinoma will have an odontogenic location. That is, it will occur in the head and neck area, that is in the jaw. But the histology, along with the regular Vickers and Gorlin's criteria, will also show extreme pleomorphism and atypia. So you will find the cells do not appear similar to one another. The cells do not appear similar to one another, and they will also show extensive mitosis and pleomorphism. So they'll keep multiplying at a rapid rate and will also invade into the surrounding tissues, which is a feature of a malignancy. So these are the two types, that's the malignant ameloblastoma and the ameloblastic carcinoma. Now let's deal with a few questions. That concludes our discussion for the day, a brief discussion for the day. Which of these is the most common odontogenic tumor? Yes, it is the odontoma. The odontoma is the most common odontogenic tumor. The ameloblastoma is the second most common odontogenic tumor. Good. Which of these is the most common histological variant of ameloblastoma? Yes. Most common is the one where you will regularly see the Vicker and Gorlin's criteria. Correct. That is the follicular type of ameloblastoma. Follicular type is also the type which is most predisposed to recurrence. Most predisposed to recurrence is the follicular ameloblastoma. Which histological subtype is considered to be the most aggressive? Aggressive will be the granular cell ameloblastoma. Very good. The granular cell ameloblastoma is considered to be the most aggressive histological subtype. The granules within the granular cell ameloblastoma are actually aggregates of lysosomes. Please remember that the granules in the granular cell type of ameloblastoma are actually lysosomes. Which odontogenic cyst most commonly gives rise to an ameloblastoma? Very important. It's the dentigerous cyst. Very good. It's the dentigerous cyst. So most likely when you see a large cystic lesion and when you do an excision, most of the cyst will look like a dentigerous cyst. That is very innocuous 2 to 3 cell layer thick flattened epithelial cells with a thin fibrous connective tissue capsule. But if you observe multiple slides, sometimes you will find that some aspects of the luminar epithelial cells will resemble an ameloblastoma or will show the Vickers and Gorlin's criteria. That is when you will think about a diagnosis of a unicystic ameloblastoma. Which histological subtype presents with keratin pearls? Yes, keratin pearls are seen where there is squamous metaplasia. Good. So squamous metaplasia is seen in acanthomatous ameloblastoma. Very good. It is seen in acanthomatous ameloblastoma. Okay. So that concludes our brief discussion for today. So I look forward to meet you and interact with you in our subsequent sessions. Thank you for listening. Good night.